Dr. Kuhls is a professor of surgery, acute care surgery division chief at the Kerkorian School of Medicine at the University of Nevada, Las Vegas. She's the chief of trauma at University Medical Center's Adult and Pediatric Trauma Center. She served as the chair of the ACS Committee on Trauma, Injury Prevention and Control Committee from 2012 to 2020, and she is the current second vice president-elect of the American College of Surgeons. Dr. Kuhls.
Good morning, and what a great talk to follow. I'm so lucky. I really want to tell you that I have so many people to thank for their efforts and what I'm going to talk about today. In the room, we have many. We have Dr. Kirby, we have Dr. Bulger, Dr. Stewart, Dr. Brendan Campbell, who's the current chair of the Injury Prevention Control Committee, Dr. Rochelle Dicker, and Dr. Saccharin, who we heard from yesterday. So I'm going to be actually talking about the efforts of many. I'll see if I can get this to work. Okay. Yes, so sort of the COT, sorry, I advanced too many slides. The COT vision and mission are, I think, very congruent with what we're talking about today. And it's really about preventing injury and really supporting injury prevention. We all do this in our trauma centers with our injury prevention professionals. And together, I think we can really make a difference. That's one resource, but as we've talked about already, leveraging that resource, those resources, all of us, we can really make a difference. And I think I'm just really proud of the American College of Surgeons to really have the courage, I think, to address this issue. So many of us are familiar with the numbers, and they are really staggering, right? You know, thousands of people die every year from firearm injuries, more from suicide than homicide, but those numbers vary a little bit. We also know that these numbers are increasing dramatically. Since 2019, firearm-related deaths have increased over 40%. It's now the leading cause of death, all causes in children. And also, when we look at motor vehicle crashes, which had been the leading cause of injury-related death, in 2018, for the population in general, firearm injuries exceeded that. And I think the College of Surgeons really had the foresight to get involved in this many years ago. So one of the early publications, and I would say the Committee on Trauma was addressing this many years before this, but there was a publication in 2015 that I felt enabled us as the Injury Prevention Control Committee to really start on this effort. And it was really 8 healthcare organizations in the ABA getting together to say, this is a problem we need to address as a call to action. And this is a slide, I've taken slides from many people that you know. This is a slide that Dr. Stewart shows in many of his talks. As we looked at this challenge, we thought, you know, gosh, it's complex, multifaceted, it's political. How are we going to address this as the American College of Surgeons? So, you know, as with motor vehicle crashes and as with many other health-related issues, we really wanted to approach it as an inclusive kind of approach and really center on what's good for our patients. And we've heard this throughout this 2-day conference and have a bias for action. And so a narrative that I think still stands true today, it's called the common American narrative, that I think most people, especially people who own firearms, feel it's their constitutional right. but we can be responsible with that right. And we've used sort of that motto in going forward to take a look at this issue. We also engaged firearm owners. So if we're going to look at motor vehicle crashes, we're going to talk about people who get hit by them, people who drive them, and so forth. So why should firearms be any different? And so Dr. Stewart actually assembled this group. I'm not a current firearm owner. I'm a past firearm owner, and I grew up in a household with lots of firearms. But how can we engage those firearm owners? And through a series of meetings, they came up with recommendations that reinforce that American narrative. I wanted to give all of some of the people in the room, I think, don't have the history of like where we've come, and then I'll talk about where we're going in a little bit. But we did a whole number of series of surveys. American College of Surgeons, like all other groups, it's a membership organization. People pay money to be members. And we wanted to really see if this is something that our members supported. We started off with a survey of every committee and trauma member, and then our board of governors, that's one of our governing boards. And then in the end, we surveyed every single member of the American College of Surgeons. And we found that the majority of our members, whether they were medical students or retired surgeons, supported the American College of Surgeons getting involved in preventing firearm injuries through advocacy and a whole number of other advocacy and policy-related issues. There were broad areas of agreement. There was also disagreement about, do guns increase our safety? Do they threaten our safety? So we were like the general population that we were really concerned, but nonetheless, there was great support of us getting involved for injury prevention to do something about this problem. So busy we went, right? We developed, all sorts of tools looking at the best available data. We have a brochure on the left that can be tailored for individual trauma centers. The red sort of in the middle is sort of kind of a primer of how to talk to your patients. We have an American College of Surgeons firearm scholar that's supported financially by several organizations. There had been really no research since the 1980s. And Dr. Stewart and others lobbied with Congress and for the first time got federal funding, and that's distributed between the NIH and the CDC. We looked at a primer for how to start a hospital-based violence intervention program. And then one of the more recent initiatives is iSave, improving social determinants of health to attenuate violence. So, we talked about the 8 organizations in 2015. So we had the first medical summit right here in the American College of Surgeons in 2019. And there were over 60 organizations that participated. And there were calls to action, and this was also published in the Journal of the American College of Surgeons. So 47 participating organizations agreed to work together on this issue. And so I think this is a good example of how we can leverage what we have. It's important that we remember what public health is and how that can really empower and be our guiding light, if you will, to injury prevention. So this is a schematic that I got from Dr. Campbell, and it talks about all of the various initiatives that together really empower injury prevention. We can go off and do multi-center trials, and I'll talk about one of those in a little bit. Various action steps, all with within the College of Surgeons and the structure of the College of Surgeons, with the goal, again, of helping our patients, lowering firearm injury and death in the U.S. Using that same public health approach, that needs to be our guiding light. And the second medical summit happened very recently, also right here. And you'll notice some familiar faces. But one of the differences is there were 5 organizations that sponsored this. So again, groups starting to work together. The summit, I'm pointing this the wrong way. The summit proceedings were recently published, and these are lists of some of the organizations that participated. And some of the key takeaways were a new coalition. We need to have a formality of working together. And violence prevention starts also in the community, and we can work together to find solutions. So in terms of an action plan, some of the next steps, again, the proceedings, if you want to look them up, and they're in the Journal of the American College of Surgeons in 2023, building a coalition to start to work together. And Dr. Bulger and Dr. Kirby have been working on establishing governance, and they're working on an MOU, and they've identified work groups, a little like our breakout groups today, to identify gaps in their domain. So the work groups are going to be looking at health professional education, whether it's nursing students, medical students, residents, all of us as practicing physicians. Next, advocacy and health policy. Advocacy is just incredibly important and really has large-ranging impact. And community engagement and violence intervention. They've already named the leaders, which again are multidisciplinary. So also continuing to engage firearm owners. So we're calling it for the time being FAST 2.0. There'll be 20 COT members that are firearm owners, 5 COT leaders, and 5 non-COT members. The focus is going to be on firearm safety. We've heard about that several times already. Suicide prevention, responsible behavior, and what to do if we see other firearm owners who are not being responsible, and identifying our families and friends who might be at risk. And there's a huge issue with firearms being stolen from vehicles, and those numbers are skyrocketing. So how we can address that as an issue as well. Improving social determinants of health. We've heard about that all day yesterday and already today as well. So this is a group that is headed by Dr. Rochelle Dicker. Many of you know her. And it is really a powerful group. And we've talked about trauma-informed care. So they've developed a curriculum for trauma centers, for all of us who work in trauma centers, no matter what our role is. And they have not only developed a curriculum, but they have 15 pilot sites. They've trained over 100 instructors to carry this message forward. And they expect to have the results soon. And I think that's moved ahead with really rapidity. And for the College of Surgeons overall, they're developing a toolkit on trauma-informed care, no matter what type of patient we have, whether it's a general surgery patient or otherwise. Also social care. We talked about mental health and all of the social needs. So again, some recommendations going forward on that. Violence intervention, prevention. Again, dovetailing very well with our work groups, community-based violence intervention, hospital-based violence intervention, and kind of alliances with other organizations, including the Hobby that many of you know about. I want to talk just a little bit about a multi-center grant that we're in the process of kind of compiling the results, and I wanted to share a little bit of it with you because I think in some ways this will help to, in a granular fashion, sort of pave the path forward. The American College of Surgeons got a grant from the National Coalition for Gun Violence Research, got it funded, and we recruited 128 trauma centers, largely level 1 and 2, geographically throughout the U.S., although the western states were they were underrepresented because they don't really have very many level 1 and level 2 trauma centers. What we found was that we wanted to really find that patients that come to us are not only our trauma activations, but they also come from our emergency department, and many of them are released from the emergency department. We also wanted to inform injury and violence efforts going forward. What we found is about a third of the patients actually were seen in the ED and sent home. So for many cases, and what I would say is, I talked with people from St. Louis yesterday to find out a little bit more about Dr. Punch's initiatives. And one of the groups he targets is the people that a lot of us don't even see because they may not even get a trauma consult. What we found, though, is overall on the firearm injured patients, that over 60% come from the 2 highest DCI quintiles, so they're distressed communities. So in many ways, this isn't really surprising, but now we have numbers. When we look at data that we asked to be collected, veteran status was missing in 50%. And we know those patients are really at high risk of both suicide and homicide. What we think we found is that the Black males, regardless of urban or rural, or no matter what the situation, they may be kind of, it may be an independent risk factor. We're in the process of actually teasing that out now. But this group appears to really stand out of being the victims of attempted homicide. And very little kind of mental history taken. We don't think it's accurate, but really, I think looking at what the contribution for mental health is. And when we look at who had discharge services, less than 20%. And of those that did, it looked like there were hospital-based violence intervention programs and so forth in those trauma centers. And among the pediatric population, it looks like single-parent children of single-parent households are especially high risk. We know about ACEs as well, and exposure to community violence. Again, it predicts not only attempted suicide, but attempted homicide as well. So there are several recommendations going forward on data that we might collect. So other initiatives, so Medicaid and violence, there's been an effort for several years led by Rochelle Dicker and others to look at Medicaid reimbursement for some of our violence interrupters and violence prevention people. There are 6 states, including California, that have already passed that legislation, and there's federal legislation that's being drafted now. It hasn't been updated, it hasn't been introduced yet. The 11th version of ATLS has 3 new exciting chapters, and I think it has a target date of coming out in 2024. So one is going to be trauma-informed care, injury prevention, and goals of care. So I think this is just such positive news going forward that, again, ATLS is promulgated all over the world. And that is the end. So I hope I've taken you through this journey of where we've been and hopefully where we're going to go. Thank you so much.